Our presentation is going to be on narcissistic personality disorder. This is our case study for JT. He is a 33-year-old African-American male presenting with numerous concerns. Incidents of narcissistic personality disorder. Numerous personality disorder makes victims to have a pervasive sense of superiority, lack of empathy, and need for admiration. Experts are not sure how many people in the US are currently living with NPD, narcissistic personality disorder, but they estimate that between 0.5 and 5%, 1 out of 200 people, suffer from this disorder. Statistics show that between 50 and 75% of cases affect men. The disorder affects all dimensions of life and can bring harm to one's mental health, leading to strained work and/or social relationships. People with NPD are more likely to commit suicide, among other complications. Many individuals hide their narcissistic behaviors and beliefs. NPD is characterized by a pervasive pattern of grandiosity, a constant need for admiration, and a lack of empathy, often beginning in early adulthood and present in various contexts. Prevalence of NPD. Between 2% and 6% of people who seek health care from mental health clinics have NPD. Specific careers are also associated with high risks of NPD. For example, 6% of forensic analysts are living with the disorder, and 20% of individuals in the military have NPD. Besides, 17% of medical students in their first year have NPD. Prevalence of NPD in clinical settings is between 1 and 15%, and the disorder is associated with a high rate of comorbidity with other psychiatric disorders. Approximately 15% of NPD victims also suffer from depression, 13.5% suffer from anxiety, and 17% have a different mood disorder. Also, 17% of people with NPD have either bipolar 1 or bipolar 2, while 14% of alcohol use disorder. Other people at high risk of having NPD includes Hispanic females, single adults, younger adults, and Black females and males. Pathogenesis of NPD. Narcissistic personality disorder is due to a combination of biologic and genetic and psychological causes. NPD can have various psychological etiologies. Parenting and impaired parent-child relationships play a major role in the development of NPD. The disorder can be linked to issues in the sense of self in early life. A child's genetic predisposition shapes the child's response to their environment. Children who have disrupted caretaker-child relationships, parental failure to meet their children's developmental needs negatively affects and interferes with the temperamental predisposition of the child. Defiances accumulate over time and lead to repeated pathogenic interactions, making the child to have behavior and expectations towards other people. Theorists argue that overvaluation or overprotectiveness of a child associated with excessive aggression, rejection, parental coldness, and frustration makes children develop narcissistic tendencies later in life. Genetics and neurobiology of NPD. NPD can be inherited, and studies show a chance of 60% of heritability of the disorder. Twin studies revealed that NPD can be inherited with a chance of between 25 and 79%, In monozygotic twins, the likelihood of inheriting NPD was 45%, while dizotic twins have a chance of 9%. A study that utilized the dimensional assessment of personality pathology revealed that narcissism heritability of 53%. Specific traits inherited include the need for approval, attention, seeking grandiosity, and the need for adultation. Neurobiology reveals that MPD relates with the characteristic of emotional empathy of individuals. A functional magnetic resonance imaging study conducted in 2011 showed that people with high sources of narcissistic inventory questionnaire had differences in processing emotions. High narcissistic scores were associated in differences in the right anterior insula, a region responsible for emotional regulation, fostering empathy, and reconstructing maladaptive cognitive patterns. Clinical features of narcissism. Narcissists may present with a number of symptoms, but more often they are self-absorbed individuals and may constantly discount others' efforts just to make themselves look good.
Hi everyone, I'm Sophia Manzi, and I'm going to continue with the subjective portion of the psychiatric assessment. And we're doing the chief complaint, which is a self-report from patient. So Terry reports, I have been feeling a little down, moody, irritable, and having problems at home, working with friends for 2 months now. Terry is a 33-year-old Black African American male. The history of present illness. Terry reports he has been feeling down for 2 months now for at least half a day every day, describing the onset and duration. And this is at home and at work, describing the location. He reports him feeling down, moody, and irritable does not cause any physical impairment, just cognitively, he knows something is not right, which describes the character. Talking with his girlfriend about his current feelings and past life makes him feel better, which are the alleviating factors. When other people speak about their own accomplishments, he would like to be the center of attention, which is the aggravating factors. On a scale of 0 to 10, when Terry was asked how down or depressed he felt, he rated it a 5 out of 10, which described the severity. Him feeling down and not being able to accept criticism at home and work is causing him major problems, and his job and relationships may possibly be at risk. For allergies, he expressed a chicken allergy, which is food. That's a mild reaction. He develops ulcerative stomatitis of the mouth. He denied any drug, latex, or environmental allergies. Terry's past medical, psychiatric history, and family history. Terry has a past medical history of diabetes mellitus type 2, which is active. Was diagnosed in April 2021. He also has an active diagnosis for headaches, diagnosed in June of 2023, and these were self-reported by client. He had no hospitalizations and reported no addiction treatments. He also denied any past psychiatric history. Terry's past family history. Patient's maternal grandmother had major depressive disorder, deceased at 84 years old. Patient's maternal grandfather is deceased, 91 years old, and had generalized anxiety. Patient's mother is deceased at age 32 from substance abuse and murder. Patient's father is alive, age 64, with high blood pressure, lung cancer, and he's a smoker. Patient's sister is alive at age 26, diagnosed with bipolar disorder 1 without psychotic features. Patient's brother is alive at age 30, has major depressive disorder. No genetic disorders were reported, and no reports of self or familial suicide were reported. Social history. Patient's report on his current occupation as a warehouse/route delivery driver. He was previously employed as a high school football coach and mentor. He lives in an apartment with his 2 children, 1 girl and 1 boy, ages 18 and 16. He is unmarried, He has one girlfriend who visits him from time to time. He identifies as male, is currently sexually active with women only, no men, and uses condoms for protection. His girlfriend denies currently being pregnant. He enjoys hanging out with his sports car club. He reports alcohol use of 4 ounces of vodka weekly and denied smoking or chewing tobacco products, denied vaping, denied any illicit drug or substance use, wears seatbelts 100% of the time, and walks 3 times a week and plays basketball with his kids. All right, so we're going to discuss the review of systems with vital signs. General, Terry denied any cognitive or memory deficits. He denied issues with appropriate judgment, denied issues with decision making, legal or financial aspects. For his mood, he admitted to feeling depressed, admitted to feeling irritable, and admitted to feeling moody. Thought content, denied feeling manic, denied anxiety or psychosis, denied experiencing dissociative symptoms. He denied obsessions or compulsions, denied visual and auditory hallucinations, and denied suicidal or homicidal ideation. For sleep, Terry denied that depression has affected his sleep. He reported sleeping 4 hours a day, which is below the average of 8. He reported feeling rested. His appetite, denied any changes in appetite, denied bowel pattern changes, denied anorexia or binge eating episodes. Trauma, Terry admitted that he still thinks about the loss of his mother each day, feels that she wasn't there for him, reports not understanding who killed his mother, and he also witnessed a murder at the age of 7 years old. For childhood, Terry admitted to growing up being separated from his siblings, admits to not having enough food to eat growing up, and admitted to stealing from others to survive. Substance use, admits to occasional alcohol use, maybe 1 4-ounce drink weekly, denies use of cannabis, tobacco, or vape products, and denied use of any illicit drugs ever. Perceptions of self, Terry denied body image disturbance, denied eating disorders, denies any pain disorders or somatic symptoms. Vital signs were as follows. Temp was 98.0 Fahrenheit, the oral route. The heart rate was 75 beats per minute. Blood pressure was 118/72, taken on the right arm in the sitting position with a large adult cough. Respirations were 20 breaths per minute. The oxygen saturation was 99% on room air, and the pain scale was rated 0 out of 10. Okay, so we'll talk about the labs, the screening diagnostics, and medications for Terry. So for the labs, we did a CBC, which is a complete blood count. It was within normal limits. We also did a CMP, which is a chemistry or a complete metabolic panel, which was within normal limits. A TSH was also completed, which is a thyroid screen. It was 2.3, which is normal. We also completed a drug toxicity screen and an alcohol screening for Terry, which was negative. There are no further screenings required at this time, as all labs were within normal limits. For screening and diagnostics, a self-questionnaire from patient was done with personal demographics, and the outcomes were positive for narcissistic personality disorder. We also did a Beck's depression inventory scale. It was also positive for depression. Another tool we used was the Narcissistic Personality Inventory, or the NPI. This is a 40-item test. It's based on yes or no responses and questions with a rating scale of 1 out of 10. The higher number of points leads to a self-absorbed, arrogant, or grandiose type of personality, which was the case with Terry. So results were positive for the NPI. His current medications are metformin, 1,000 milligrams, which he takes by mouth twice a day for glucose control of diabetes mellitus type 2 until discontinued. Also, he takes Tylenol 650 milligrams by mouth as needed every 6 hours a day for headache pain. Patient denies taking any prescribed psychotropic medications. The primary diagnosis that we formulated for Terry was narcissistic personality disorder. And on the DSM-5 scale, that would be a 301.81 for diagnostic purposes. And then the ICD-10 code is F60.81 for billing code. According to Barlow, the defining criteria for NPD D, based on his grandiosity, sense of self-importance. For example, he always harped on his achievements and reverted all conversations back to himself. Terry also believed that he is special and constantly talks about having celebrities as friends and that he knows them closely, although no one has seen Terry around these celebrities. Terry's lack of empathy, exploitation of others, his sense of arrogance, and being envious of others all pointed to this diagnosis. Some differential diagnoses that we formulated were bipolar disorder type 2, oppositional defiant disorder, adjustment disorder with depression, and borderline personality disorder. The primary diagnosis was ruled in due to client's thoughts of grandiosity, as evidenced by him stating that he knew celebrities that were his friends, although nobody had ever seen them. Him wanting to be at the center of the attention at all times. Um, Oppositional defiant, we didn't really rule that one in because his insubordination was only shown at work. He wasn't really defiant at other times. Borderline personality was ruled out as client did not have any suicidal behavior or transient paranoid ideation or severe dissociative symptoms, nor did he have impulsivity such as reckless driving, spending, or sexual encounters. Histrionic personality disorder was ruled out as these people tend to be actors and may cry hysterically at a movie, and they are also uncomfortable being in the center of attention. And Terry loved and preferred to be the center of attention at all times. The problem statement and chronic diagnosis. This is a 33-year-old male with presentation for feeling down or presents for feeling down and having problems in his personal life with failed relationships with prior girlfriends, his children, and on a job with his boss. Terry does not seem to be aware of him per se being the one to cause any issues and instead insists that the issue is with everyone else. Terry loves being the center of attention and always brags about his sports car. He reports issues with insubordination on a job and fears his job may be in jeopardy. When he meets with other individuals and they want to talk about themselves or others, Terry quickly diverts the conversation back to himself. He poses with grandiose ideas, stating that he has many celebrity friends, although no one has ever seen him with these celebrities. Whenever his girlfriend and kids tell Terry that he has hurt their feelings, he quickly resorts to a lack of empathy and tries to put fear into them so they will feel sorry for him instead. Terry also harbors feelings of hostility towards his deceased mother and states she was a drug addict and she was never there for him. Some of the remaining diagnoses that were discussed at the visit were depression, bipolar disorder type 2, oppositional defiant disorder, borderline personality disorder, and adjustment disorder with depressed mood. Certain positives for Terry were feeling down, moody, irritable, poor insight as to how he made others feel, feeling no guilt or remorse. The positive Beck's depression inventory scale, that was positive. The narcissistic personality inventory score was also positive. Terry is blameless. He's self-absorbed and claims to be associated with celebrities closely, which display delusions of grandeur. His chronic diagnoses are diabetes mellitus type 2, diagnosed by his PCP, and then headache unspecified, diagnosed by his PCP, both in 2023. So here we get an overall picture of how JT's actions have affected him and everyone around him. We are able to dissect each phenomenon to arrive at the correct mental health diagnosis. Terry's adjustment disorder was a result of his mother's death at the age of 6 years old, which he could never seem to accept. Terry's mental status exam and the physical exam. Terry's a 33-year-old pleasant male who is alert and oriented times 3. He is calm, has a cooperative approach. He's well groomed, no body odors. His rate of speech and flow are reasonable. He's dressed appropriately for the weather. He has a normal mood and appropriate affect. Is able to use and identify metaphors and abstract thoughts appropriately. His cognition, memory, and orientation to space and depth are intact. Terry reports that he's been feeling down and is having problems on his job and in his relationship with his kids, girlfriend, and with his boss at work. And his job may be in jeopardy. So for his actual physical exam, his appearance, he's well groomed, dressed appropriately for the weather. Posture is erect. He has a relaxed posture. His speech, the rate and flow of speech are reasonable and well paced. Continuity of speech is appropriate, and the content of speech is reasonable. For emotions, affect is appropriate. Mood is depressed, but he is calm and makes good eye contact. For intellectual functioning, his vocabulary is reasonable. He can use metaphors reasonably, and his abstract thinking is intact. Perception. Client does not respond to hallucinations. He expresses no false perceptions and appears comfortable in the environment. Thought process. Continuity of speech is appropriate. No auditory hallucinations or visual hallucinations. No delusions of persecution. No ideas of reference. No thoughts of wanting to harm other people. So continuing with the assessment and the physical exam. Cognition and sensorium. Patient is awake, alert, and oriented. His sensorium is clear. He's aware of his surrounding. He knows the adequate or proper time, date, and place. The rate of speech and flow is reasonable and well paced. Cognition, memory, and orientation of space and depth are normal. Incidents and judgment. Client can identify the consequences of his actions. Thoughts are goal directed and specific, and client has poor insight, how he functions around the whole world around him. He shows no accountability or remorse for the ways he makes others feel or behavior. He does not appear restless. Client has effortful motor behavior, no psychomotor retardation observed, and maintains eye contact. Sensorium is clear. Client is aware of his surrounding, knows the time, date, and place. So for the plan, treatment, and patient education for Terry, no further labs are required at this time. We do want to start cognitive therapy, start interpersonal therapy, and we want to teach him coping strategies such as relaxation to help face and accept criticism. We also want to start Terry on an SSRI, or a selective serotonin reuptake inhibitor. We want to do Zoloft, and we're going to start out with 50 milligrams per day by mouth times 30 days. So the quantity prescribed would be the number 30 with no refills for depression. Patient education. We will educate Terry on suicidal ideation and how and when to get help. We'll give him a number or pamphlet for a suicidal hotline. Some common side effects we'll teach about from Zoloft are nausea, diarrhea, insomnia, sexual dysfunction, and restlessness. If sexual dysfunction occurs, we will switch to bupropion, 300 milligrams per day. A 30-day supply with GoodRx coupon will cost $22.62 for the Zoloft, and if we end up having to switch to bupropion or Wellbutrin, the cost with GoodRx will be $23.97 for a 30-day supply. Terry will be educated to call the psychiatric NP with adverse side effects and serotonin syndrome. If it does present, that's something that he will need to call us for. And that can be observed with shaking or shivering. If he presents with those, then he can call the NP and let them know. Terry will also be educated to not abruptly stop any medications. He will need to follow up in 2 weeks and keep all follow-up appointments that are scheduled. Strategies for disease management. Self-management techniques are going for a walk, swim, or read. Ways to develop skills are to have Terry attend help groups with others who have mood instability, attend cognitive behavioral sessions, do positive self-talks every day to change negative perceptions of self. Research, treatment, and options are extremely limited when it comes to narcissistic personality disorder, but when implemented, it focuses on treating the narcissist's grandiosity, their hypersensitivity to being evaluated, and their lack of empathy for others through cognitive therapy. Cognitive therapy works to replace their fantasies with more realistic and attainable goals. Interpersonal therapy focuses on solving problems in existing relationships and learning to form new interpersonal relationships. Coping strategies such as relaxation are also used to help and face and accept criticism. Because narcissistic people are depression prone, they will be treated for this as well if present. SSRIs are always the first line of drug for depression unless panic disorder criteria is met. So continuing with the treatment plan and anticipatory guidance. So for disciplinary referrals, none are required at this time. Anticipatory guidance will be to educate the patient on annual flu vaccine, doing a COVID vaccination if he has not had that, or a booster if required. Terry will need to see his primary care physician or NP once yearly and as needed to have primary labs drawn in to do STD screenings. Annual eye exams with ophthalmologists should be done every year. Dental visit for cleaning should be done twice yearly or as needed. Some cultural and spiritual considerations to consider. The individual may be less apt to take medication due to possible stigma that could be attached. There will also be a need for strong family support to help Terry get through his narcissistic personality disorder. Although our client is seeking psychiatric mental health care with a psych NP, we must always be looking for any underlying medical reasons for the given concerns or complaints before we are able to assign or diagnose the client with a mental health disorder. And the last slide shows our references, what you can look at if you need to see or do any further research. And we want to thank you so much for taking time to listen out to our presentation. Goodbye.